Sometimes you may have a fluid level or a hematosalpinx, and Doppler may help you find vascular thickened tissue with an associated salpingitis. The plicae in the fallopian tube may thicken, forming thick, incomplete septations into the lumen of the tube. This has been called a cogwheel sign and can be seen and help make the diagnosis of a hydropyosalpinx. Now, this is a more severe case in this patient who presents with diffuse abdominal pain and fever. There's complex fluid deep to and extending into the cul-de-sac. Now, when we increase our depth, we can see that there's more extensive involvement. We see complex cystic mass that appears to wrap around the uterus. In the coronal or transverse plane, we do see that this extends laterally, and we can see the extent of the involvement better with this increased field of view or depth. When we look at the adnexa, this complex cystic mass cannot be separated from the adjacent ovary, and this is characteristic of tubo-ovarian abscess. Now, how can one tell the difference between this and cancer? And the answer is really mainly by history. Without the appropriate history, both may present with a similar appearance. This is the CT scan in the same patient. We see a complex cystic mass that is extending from each adnexa into the midline, indistinguishable from the ovaries in this patient with tubo-ovarian abscess. Now, this is a case that proved to be difficult without the proper history. The original report, or the original request read, pelvic plane exclude torsion. We can see that the ovary appears enlarged. It is posterior to, or perhaps displaced, posterior to the uterus, perhaps in the cul-de-sac, as we can see here. And it's unclear whether there was reliable Doppler flow. So in the setting of acute pelvic pain, torsion can definitely present with an appearance similar, such as this case. But when the referring team came to discuss the case, they provided a very different history of acute pelvic pain, fever, discharge, and severe tenderness on examination. And in that case, tubo-ovarian abscess can be raised, which in fact was the case when this patient went to the operating room. Now, there are some pitfalls because endometriosis and hemorrhagic cysts may also cause acute pelvic pain and present with a similar or overlapping appearance. It is important to make sure that the patient is not pregnant, as ectopic pregnancy would be included in that differential diagnosis. It's also important not to forget that non-gynecologic causes can also cause pelvic pain. Hemorrhagic cysts have many appearances and may be difficult to distinguish from other ovarian pathology. A retracting clot may present as a mural nodule. However, retracting clots tend to have concave margins. Fibrin strands may also appear to represent septations in malignancies. However, fibrin strands are thinner, less reflective, and with no flow on Doppler. Hemorrhagic cyst walls tend to be smooth, whereas in malignancies, the wall can be irregular. Hemorrhagic cysts will resolve over time, and it's much more common for a hemorrhagic cyst to mimic a neoplasm rather than the opposite. Now, here are some images showing evolution of a hemorrhagic cyst. Acutely, they may appear solid, more echogenic, but over time, as the clot evolves, we see more cystic spaces forming. There's no flow within a hemorrhagic cyst. Over time, as the clot retracts, it may form some concave or straight margins, such as in these cases. And with even more time, these thin, poorly reflective fibrin strands may be seen. Here is a patient who presented with left pelvic pain and the question of a hemorrhagic mass with hemorrhage extending into the pelvis. It is much easier to make the diagnosis of a hemorrhagic cyst on ultrasound. We see a hemorrhagic corpus luteum cyst in the left ovary. But again, it is difficult to tell whether the left ovary is displaced due to the size of this cyst. And when the cyst is large, it may be difficult to find flow in the ovary due to stretching of the parenchyma or even inability to find parenchyma to interrogate. And even With all the technology, it may be difficult to tell whether this ovary is torsed. Now, endometriosis presents with intermittent or cyclic pelvic pain. 80% of endometriosis is found in the ovary. Endometriomas appear with uniform low-level internal echoes. They may present with hyperechoic wall foci. The cysts may be irregular in shape and multiple and bilateral. Here are some examples. You see well-defined cystic structures with uniform low-level internal echoes. You may see bilateral cysts or cysts with irregular shapes rather than perfectly round. You may see echogenic foci along the walls. And the periods of repeated bleeding may cause adhesions that lead to hydrosalpinx. Now, this is a patient who presents with endometriosis, diffuse pelvic pain, and fever. Multiple prior ultrasounds that had a very similar appearance to this, complex adnexal masses, fluid levels, low-level internal echoes, all of which can be explained by the diagnosis of endometriosis. However, blood is a setup for infection, and in this patient with diffuse pelvic pain and fever, the question of pelvic inflammatory disease and tubovarian abscess should be raised, which was found in this patient at pathology. Now, here is a 38-year-old who presents with abdominal pain and distension. We have a sagittal view of the uterus, some complex fluid in the cul-de-sac, and posterior to the uterus we see this dilated tubular structure coming to a point. As we scan towards the adnexa, we see perhaps a cystic structure in this area, and further to the right, we see the right ovary with a cystic structure adjacent to it. Cine shows the right ovary, the cystic structure, and this dilated tube that is coming to a point where we see this cyst with low-level internal echoes. This is a case of endometriosis causing a small bowel obstruction. Here is the dilated small bowel loop and the hyperattenuating endometrioma causing a narrowing of that loop. This brings me back to the 4 challenge cases I showed at the beginning. This was a tubovarian abscess that had the appearance of torsion, a hemorrhagic cyst within a torsed ovary, a hemorrhagic cyst in a non-torsed ovary, and a case of endometriosis. Thank you for your attention.